we'll talk about rhinoplasty assessment, which is, I think, is really important for your future career as juniors and if you're interested in this area, but also for the exam, because the way I've presented here is a systematic way, which makes it easier to think about how to assess the nose and the patient in general. And I think it's really useful for the exam purposes, but also for your daily practice. So rhinoplasty assessment, we published a couple of times. This one in ENT Masterclass goes back a few years, but is available online. You can read it, and it's a shorter version of the newer chapter, which is in Scott Brown, the last one, which we expanded on, and essentially have what I'm going to talk about today, but with some expansions and references. So here are analysis, analysis, analysis. Why do I say analysis 3 times? Because we're not just going to analyze the nose when you see a patient coming for rhinoplasty. It's really essential to analyze the patient themselves in respect of so many things, in addition to the face, in relation to the nose, and the nose itself after that. When we think about the patient, the psychology of coming for rhinoplasty is really important. So you need to have somebody who understands what the deformity is and have a realistic expectation. This is an old graphic published by Gordon, who was a plastic surgeon a few years ago, showing that if the concern is too big for a small deformity, it's a red area where the patient that is that high risk group that you don't want to operate on. But the patient concerned with a deformity that's big, it's a green area, so that is an easier one that you want to deal with. So lots of studies in the past, but like this older one published years ago, says that poor results are often based on emotional dissatisfaction than technical failure. So you've done a nice operation, looks good, but the patient expected something more, so then it's a failure in their eyes. So that's why assessment of the patient is essential. I always do this. I created this little diagram years ago, and I use it all the time. I say to the patients, if a nose has 5 grades of goodness or badness and so on, the worst nose is number 1, and the second one is number 5, and yours is, I usually say 3, so I do not set anybody, or 2. You can jump 1 stage by improving it when you do a rhinoplasty. And if we're lucky, our tissues help us and work really well with healing and so on, you can jump 2 grades, but it really is impossible to jump further than that, let alone from here to here. So make them understand that tissues don't allow us, or do allow us, a certain extent of change, but not everything. So this is a nice one we always show when I'm sure all of you probably know this, the ideal patient, which actually does work in real life. Secure, young, listens, verbal, intelligent, attractive, usually young ladies who know what they want. They do have some deformities. You want to correct them. They exactly tell you, I don't like the tip, I don't like this bit of deviation, I don't like this. I just want it to be like that. And if you can achieve this, they're really happy. Then gets to, sadly, with males here, single and mature male, overly expectant, narcissistic, Simon is the one that you wary of and you want to be careful with. And these are the patients that are never happy. Usually the nose doesn't look too bad, like this patient of not mine, who was never happy with the nose and kept going on because he's just obsessed with it. He's got good dysmorphia and kept going until had 7 operations, which can end up like this. It is common with males, it is true, but there are some females like this, but usually they are older. So interesting about, there's not many studies on this. So you will get patients, that's a different category now with a bit of unusual things that they ask you for. I want to have her nose with pictures like this. That's a band, by the way. So why you think you can have a nose? Because I have the same eyes. And obviously you want to be careful with a patient like this. And patients who really get obsessed with a really particular perfectionist and come with diagrams, teach you how to do the rhinoplasty for them, you'll see a lot of things like this. And these patients do not really have realistic expectation or don't understand the whole process. If you could get through to them and you think you've actually achieved an understanding between you and them, yes, but often this process involves a psychologist. Here's a patient that I saw early in my career, and when I was not sure, I referred it to the psychiatrist actually, and these are the 4 diagnoses that they came up with, and this is the worst one because these patients will never be happy. I'll talk about it in a minute. Delusion disorder, alcohol dependence, mild depressive. If you operate on a patient like this, they will never ever be happy. They'll keep coming back and there's always something wrong. So these are the groups of patients you want to avoid. And it's a minority, by the way. So because 95% of the time you do rhinoplasty, the patients are really happy, you achieve what they want, and that's it. But it's a minority with difficulty that will make your life difficult, and they will never be happy, and they're always going to be there. What is dysmorphic disorder? We'll talk about in a second. Patient who demand too much in everything, not just in rhinoplasty, you'll find the patient who demand too much, usually just maybe aggressive too much, they expect too much from you. Just have to be careful with them, especially in rhinoplasty. And then, interestingly, the patient insisting on secrecy. We've found this, there's studies on this and data. Rhinoplasty is a big psychological impact, has on the body and the face and psychology of everything. If patients do it on their own and insist on secrecy, not involving friends or family and so on, they may not be happy because of the stress afterwards. You really have to ask them to involve friends or family with them. So be careful with that as well. Surgeaholics is the one I showed, like Michael Jackson there, who's had multiple operations and they never ever satisfied. Usually have to come to a stage that the nose is so scarred, you never make it better. So you just have to avoid these people as well. The ones who had started to have more follow-up operations and so on, you're probably not going to achieve much for them. Obsessive patients, like the diagrams, being diagrams like I showed you, and really think they can achieve something exactly precise like they want, and they show you so many pictures and ask you the question so many times again. They will click here, and you just have to be careful and not consider operating on them. That goes as well with a perfectionist who think they can everything adjust in half of the millimeters, and you have to explain to them these are human tissues that are not controllable, like a big piece of something that you're going to create a statue from and so on. But you just have to be careful with people who think you can actually perfect a nose. Obviously, we always don't like impolite patients, and they are impolite with the staff, not you usually, but later on, if they're not happy, they may be impolite with you as well. So be careful with them. On the opposite spectrum are people who flatter you too much. You're the best ever in the world. I don't think anybody else can touch my nose. So what's here? What's the problem here is I expect too much from you. Expect that you give them a perfect nose and everything else, and nobody's perfect. And you have to bring them down and just make sure they understand all the pros and cons of the surgery and so on. So just think about these groups when you're actually seeing the patients. And if you're really not sure about any of them, refer to a psychologist, psychiatrist, and do not operate until you're really sure. So when you doubt, don't touch them. I work with a psychiatrist. Initially, I worked with Dr. Tim Beale, who is basically, David Veal, he is the leading psychiatrist in body dysmorphic disorder in the country. He published all these books. So I send him the patient who are really serious. But psychologists actually quite often is easier and better. And I have appointed a psychologist to work with me in NHS. She's a psychologist in rhinology and rhinoplasty. So she sees both my patients, rhinoplasty patient, anybody that I'm not happy with, anybody who comes for secondary surgery. But obviously, because I do a lot of rhinology as well, so skull base and so on, she sees a difficult patient. But I could see in the majority of the time, it's the rhinoplasty patient who needs to be assessed. So she has done her thesis on that, and she's published on rhinoplasty and aesthetics. So go back to body dysmorphic disorder, very well described by Marcelli in 1891, who was a psychiatrist from Padua. It is a subjective feeling of ugliness or physical defect, which the patient feels is noticeable to the others, although actually the appearance is within normal. But most of the time they look fine, like this lady here. That was in the BBC. There was a program about her, like a full 1 hour program. She thinks her nose is horrible and that she's ugly. She takes 300 selfies a day. Obviously, she was happy for her to be put in that program, and she was treated. So the condition is treatable with psychotherapy and medication and so on, but it is difficult, and they're never happy with surgery. Unfortunately, there's not really a standardized way of finding them yourself, but we do use questionnaires to just get an idea from these patients. I do use a questionnaire, I'll show you in a minute. We did a study a few years ago, me and Peter Andrews and the Royal National, which we looked at a number of patients coming through the door for rhinoplasty and a control group. We use a standard body questionnaire. It's body dysmorphic or the questionnaire is whole body, is not rhinoplasty one, which cover these 5 questions, asking the patient about how they're obsessed with their appearance and so on. And really interestingly, more than we expected, 32% of the patients coming for rhinoplasty were positive for that questionnaire, which is very high. But when we refer them to psychologists, they excluded 12%. So 20% of patients coming to your clinic for rhinoplasty can have PDD. This is an international figure. It does apply everywhere. 5% of the patients. So you really have to remember that. Sorry, 20% of the patients. So 1 out of 5. So you have to remember that. It's a big thing. 4% of people coming through the door in the Royal National ENT Hospital had body dysmorphic disorder. I don't know if this applies everywhere else. Maybe it was King's Cross or anything. Sorry, guys, I just say that. But 4% of the population that came through the door for ear problems and so on had body dysmorphic disorder. So it is common. So use screening questionnaire. It's a nice idea to do that. There's more and more of them, and every day somebody publish a new one. That's an old one by Lohaus and colleagues from Holland, and quite good ones. 5 questions, easy one, just specifically related to the nose. So instead of the whole body, it's nose, and it can give you an idea. Other one which was specifically also done for the nose with more question, more detail, published by Filio Lekakis and Peter Hellens in Belgium, and it's slightly more detailed, and it's also a nice one, which I'm currently using. The Royal College of Surgeons has actually accepted another questionnaire, which is much longer. But if you want a short one, you use one of these. I suggest you check the Royal College website as well, because it's a very long questionnaire. But in the future, one of these questionnaires will become a standardized one. So do not operate when in doubt, and consider referring to a psychiatrist or psychologist if you're not sure. If you have that gut feeling, ask the patient to come back, talk to them again. But if you're not sure, just don't do it. Now, this short bit about facial aesthetics and facial asymmetry. You have to be sure that you look at the face as a whole. The ancient Egyptians looked at symmetry. This is so symmetric to a degree that it's unnatural. It doesn't really exist in real life. And it was Leonardo da Vinci who looked at the face with fifths and thirds, like I'll show you in a minute, and thought about asymmetry more. And this is what we talk about, the facial asymmetry, the way to measure it. You divide the face into these horizontal thirds from the chin, nasolabial angle, to the root of the nose and hairline. So they should be fairly symmetric. And the fifth from border of the ear, lateral canthus, medial canthus, and again, all the way, fairly symmetric, but they're not really symmetric like this in everybody. In the studies that we published, a couple of studies here a few years ago, we've shown that 99% of people have some asymmetry. So complete symmetry is unnatural. Sorry to cover this, but you can see the eyebrow is much higher here than this. This is extreme asymmetry, which you will see in a small number of people. But this is hard because you have somebody with this severe asymmetry. It can give an illusion of deviated nose or twisted nose. And when you actually, even you straighten that nose, whatever you do is not gonna work like perfectly. And often the case of patients start looking at the face more and more. They see the asymmetries and they come back and say, since you did rhinoplasty, this eye is higher than this eye, this eyebrow. So really have to point it out to the patient and tell them it's impossible to make that face symmetric, even if you straighten the nose. Something important to think about, especially with twisted noses. Now we'll talk about the nose. So like everything else, inspect, palpate, do the photo review, and then we plan. So easy way of thinking about things, 7 things you want to look at: skin, deviations of the nose, length of the nose, projection of the tip, dorsum shape, tip itself analysis, and then the alar base. With the skin is very important because you can have thick or thin skin. Thick skin, you cannot achieve really a small nose, and really remember that, because still a lot of people will have patients with very thick skin, want to be a smaller nose and expect so much. You do it and it's still the same. The skin rules. It's very important. Thick skin like this, you cannot make the nose too narrow, but and it doesn't shrink as well. But if you create some irregularity, it's going to be hidden. So that's the one advantage here. Thin skin will give you a lot, but if you create a minor irregularity, it will show. So really look at the skin. Then look at deviations in a nice systematic way. In NHS, you'll see a lot of deviated noses. So try to think about it on thirds. Upper third is the bony vault, middle third is the upper lateral cartilage and the dorsum septum, and the lower third is the lower lateral cartilage, caudal septum, and the alar base itself. When you think about it this way, it's easier to actually analyze it and plan your surgery. All of these are deviated to one side, one upper and lower and middle to the left. This one in the middle, this one on the right, this one sort of the left, this one in the middle, this one right, this one middle as well, and so on. Think about it this way because it helps you to analyze and plan your surgery. Length of the nose. What's the length of the nose? It's from the nasion here to the tip. And a lot of patients will come to you, my nose is too long, doctor. And there are many ways of measuring it, but the simplest way is it's this one, stomium to mentum. So the stomium between the lips to the mentum should be roughly equal to that length. So you can even just put your hand like this or a ruler and show the patient, they can tell. But if you want to be more precise, get that equation from the tip to the stomium and multiply it by 1.6. There's lots of other angles, but if you're quick in the clinic, just do the stomium to mentum, and then you can tell if that nose is long or not. Projection of the tip is really important. A lot of patients say my nose is too big from the side, or tip is too long, and the projection is from the tip here to the alar groove. And this is a really nice way of measuring it, and it's actually good for the exams. This good equation, RL good, or good rule, or good equation, which the distance from the tip to the alar groove divided by the from the tip to the nasion is equal to 0.55 to 0.6. So remember that one, because that is really important. It's been asked for the exams a lot as well. So you could do that easy on the photograph of the patient and measure it. You look at this, your eye will tell you this is Pinocchio nose anyway, but sometimes equation is important. So when you've done it with this gentleman here, 0.88, really wrong. That's very overprojected. Triangle of Powell and Humphrey, lots of studies were done in the nose. I don't really think anybody asked you details about this. It's nice to know them for research, analysis, and so on, but you're not going to use these in the clinic. But these four main angles are the ones that people ask about. Nasofrontal angle here, which is open angle, 115 to 135. Then there's a nasofacial angle there, which is a small angle, 30 to 40. Imagine if that angle is bigger, the nose is projected too much. Nasomental angle, it's the one that goes between the nose and the mentum. It's like this here, and it's an open angle again, 121 to 32. Then the mentocervical, which shows the relationship between the tip of the nose and the chin, and 80 to 95. So these are the main angles from Humphreys and Powell. Lip-chin relationship is very important. This is a very easy way of looking at it, which is that the upper lip is 2 millimeters in front of the lower lip, and if you put the line through them, it goes through the chin. So that's a very simple way of just telling the patient the chin is too small, it's too big, or you can use the triangle of Powell and Humphrey, but here they are. The line is not going through the chin, it's small retrognathia. Line is going in the chin, is prognathia. So that's another way of looking at it. And here's a patient before and after. Rhinoplasty in the line. You can see the line is going outside, sorry about this, and then in there. The dorsum, you want to look at the dorsum from the front and quarter view and the lateral view as well. If you don't have a deviated nose, a nice aesthetic looking nose, you see that brow tip line nicely, like a shadow. You see that in pictures a lot, and you see it from the side here. Something talked a lot about nowadays, but it's just a shadow basically. And that is an aesthetic line, natural aesthetic line, or lateral aesthetic line, brow tip line. And this is what I try to create. Where is that line? You can't see it, but here you can, after straightening that nose and adjusting and narrowing the middle third. You see these lines. That's what you try to achieve, especially in women. On the lateral view, men's dorsum should never be low like this, ever. It just doesn't look right. It should be a bit higher, just straight like this. If you lower the women's dorsum too much, it would look Scandinavian. If the patient's Scandinavian is okay, but like you see, a lot of patients in the Middle East still have a rhinoplasty like this. It doesn't look natural, and you can always tell they had a rhinoplasty. So it should not be lower than maximum 2 millimeters. So tip, you really have to spend your time, look at the tip, look carefully at the skin, look at the shape of the alar cartilage. You'll see them underneath quite often. You could actually almost follow them, like the shadow under the skin, especially with thin skin. Look at the size, look at the shape, look at the asymmetry between them, any bifidity space between this medial crura or the domes, and the rotation of the tip, which I'll show in a minute. There's lots of terms describing various tips, but I don't use them that much, but you could say boxy or bifid, like here, bulbous like this, or amorphous. These are the main ones you can use. Amorphous because the skin is so thick you can't see anything underneath. But you can use these terms, but I like to describe the cartilage themselves systematically. Always remember the difference between men and women in the lateral view, because the nasolabial angle is really important. It should be 90 to 95 degrees in men, not open like this. So in women, it's 95 to 105. That's really important. It makes a big difference to feminization of the nose. It will look too odd in a man who's got a tip that's very, very lifted. Columella show is that distance when you put a line through the anterior vestibule here and the one posterior part of the vestibule, 3 to 5 millimeter. I would say 3, that's the range that's published everywhere, but 5 millimeter can be a bit big sometimes. So I would say 3. Then finally look at the alar base, because a lot of patients would say, this is too wide, doctor. So the easy way of measuring it is between alar base and intercanthal distance, but also the width of the dorsum should be 80% of the alar base. The alar base is also equal to that between the medial canthal here, should be roughly that. If it's a bit bigger, it's okay. It's widely much bigger. It's abnormal in Caucasians, obviously, not in African patients. So this is the basal view. When you look at the base like this, and again, a Caucasian or Mediterranean patient as well, you'll see the anterior third, which is the infractive lobule, is a third, and then the rest is 2/3. If the nose is over-projected, this will be too long here. And when you put a line through the columella that passes when the divergence of medial crural goes there, that's half and half. That's the symmetry of the alar base. And if you draw a triangle across it like this, it'll be symmetric. That's in Caucasian noses, a Mediterranean. Clearly completely different from the point of view of African noses. Then you're going to inspect the internal nose, because all ENT surgeons will look at everything. So examine the septum, turbinates, internal valve, alar collapse, everything. And that's just to take a couple of minutes. So I'm asking the GP trainee here to just look at the camera. I didn't say anything. So I'm just checking if she's collapsing. She's not, because I didn't ask her to breathe. Here's that valve, which is between the upper lateral cartilage, the septum, the turbinate, just across such sectional area. So if you ask her to breathe consciously, she will collapse. Now I'm going to ask her to breathe. So, see that? She's collapsing. So, now finally, we just have a couple of slides now. Palpating the nose is really important, yeah? You have to feel everything, skin irregularities, push the tips. If recoiling, if it's not recoiling quickly enough, means it's very weak. Feel the cartilage, feel the spine and the septum with the glove like this, how strong it is. And take some photographs. Essential, essential, essential. You cannot really operate on rhinoplasty patients without photographs. So use them for consultation, pre-operative planning when you're sitting with the patient, reference during surgery, and assessing results. Medical legal, if you have a problem, you don't have photographs, you're done. These are the photographs go through that Frankfurt line, which goes from the tragus here to the lower bolter margin. That's how the head is fixed. And there's lots of guidelines, but this is online. You can find these if you want, if you're interested in taking photographs, to learn about them, you can download them. And these are the standard views, the frontal, the laterals, and the quarter views with the superior view and inferior view. These are the standards you get in any clinic. Sometimes you get more close up, and this one completely basal, doesn't show the dorsum. I like these two, they're useful. That skyline view is good for deviated noses. It's not a routine one, but you can get it if you want. And if you like, if you have computer software, it's really good because it does help you to give a patient idea. And I think it's really useful to actually manipulate the photographs in patients. And there's so many softwares, but nowadays, guys, I can't put everything because it's coming all the time. This is the one, professional one I had for years, but you can even nowadays download it from the iPhone for nothing, and you can use them. But you can even get the 3D ones. I'm playing with my nose here. 3D is catching up. It's still not as clear, and it's variable opinions. I use it sometimes. I still like the ones that the standard one. You can do anything with that nose, change it. I made it over projected here, then I'm going to make it under projected, make it feminine. Doesn't look right, as I showed you earlier. So there's data published. That's an old paper by David Roberts and Henry Sharp, which showed that really patients are happy with it, improve the communication, and you understand the patient expectation from that. But should not just play too much and think you can do anything. Just don't, remember, do what you can do in surgery, and don't tell the patient this is exactly what it's going to look like. Give them something written like this if they want the photographs. Image manipulation is means of communication and does not imply guaranteed outcome. So finally, documentation, write everything, draw sheets, diagrams, write your surgical plan, and do the consent. If you like, you can download things like this from internet, but I just draw my own things, and you can also get software that can click and shows you what you're going to do. Informed consent, like everything else, essential. Patient must be able to make an informed decision about having rhinoplasty. If there's an alternative treatment, if applicable, tell them, of course, and discuss everything, pre-op, operation itself, post-op recovery, time of work, exercise, travel, everything. Tell them about complication of anesthesia. I give them written information about everything, so they have to think about it after. And then discuss the possibility of a revision is important, because rhinoplasty worldwide has a highest revision rate of any operation. So conclusion, analysis, 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 like I said earlier, and systematically, like I do it, patient, face, nose, inspect it, palpate it, photo reviews, and planning. Thank you very much. Sorry.
All right. Now tell me what, in the real world, Professor Saleh, when that patient comes to your door, what's going through your mind from the second they enter your room?
Quite often, you will tell really quickly that patient is realistic and they're good. Sometimes you get a hunch from the way they present themselves, from the way they ask you questions, or they immediately bring this big folder of things. So the minute this happens, I go through the consultation as normal, and everything with the photos, everybody's the same. And at the end, I would say, I think, you expect too much from this operation, and I really want you to think about it again and consider all of what I said to you and come back another time. Yeah, so that's the first thing. Or if it's very obvious and it's impossible from the beginning, I don't think I can achieve what you would like to have done. I can always offer you to have a second opinion from somebody else. Yeah. Or if I feel, that's a third option here, there's something very obviously psychological going here. I'll say I work routinely with a psychologist who sees many of my patients. And sometimes there is an overlap between what we think and what we feel about the nose and the realistic shape of the nose. And the psychologist really helps with this. And if you'd like, I can ask her to see you. Yeah. So I say, I bring it down to them in an easy way, because if you tell a patient directly, they're not going to be happy at all. And they accept it.
Patient, what about the patient that says, I'm not happy with my nose?
And total, yeah, that's.
And you say, which bit of your nose? They say, my nose.
Yeah. So which bit of your nose? Yeah, exactly. That's a red flag. You want the patient to come and tell you. So this is why I asked them the first question. Nice to see you. So you hear about the nose? Yes. Tell me about it. I don't like the tip and this bit here because it's bent and my profile looks like that. Nice. And I look, they're right. But then you look at a patient and they got really, really horrible tip. Yeah. They said, I don't like it here. Something else. Yeah. So they don't know what they actually think about. They're not sure about what's wrong with the nose, or my nose is not right. Yeah. Or it's just too big. I don't know. There's something wrong with it. So they need to be specific. So I asked them the next question. Okay, too big. Do you think there's certain areas that you really don't like more than others? Yeah, just go into details about it a bit more. And if you come up with the goods and they understand what it's like, yes, then you can go on and keep going. But when they just say, I don't like my nose, they don't like the whole body. Is all psychologically something else wrong. Yeah, we're not psychologists, but really have to be a little bit in that rhinoplasty area, because people will have different psychological problems, put it in the nose, often, like we all call them rhinocentric. So a lot of these patients, like working with Deborah, our psychologist, recently, opened my mind a lot of things. We've just written a paper, we haven't published it yet, about other things, not just body dysmorphia, is the mental image. Some people, why do people come for rhinoplasty and somebody else with the same nose are happy? There's some mental image, so there's something that go back from childhood and so on, and something to explore quite often in these patients. But in the majority, obviously, there's something in the nose that you can change anyway. So you really have to explore the patients very well and make sure they know exactly what's wrong, and you think it is wrong. You agree with what they think is wrong. Looks exactly like what they think. When there's not, with a contradiction, there's something not right.
Couldn't agree more. It's a two-way process, and you have to feel as comfortable with the patient's motives behind surgery. Hesham, you mentioned consent. Consent's extremely important from a medico-legal perspective as well. Okay, so do you allow your patients an opportunity to reflect? How many times do you see them before surgery?
Twice, minimum, yeah. So I always tell them, this is your just first consultation. You're not going to come for surgery immediately after that. You must come for a second one or more if you like. So I see the minimum twice. Quite often they will come more than once, especially if they booked surgery like a year ago or something, and you come back again, because many patients will book it to be done a year later. With COVID, obviously, a lot of patients will book ages ago. So I'm seeing them all again and again and again. So about minimum twice, and quite often it's more.
So Max, I hope that answers your question there. And Max has just added a second point. Is that all patients or just the ones you have alarm bells for? I'll just say, if you have alarm bells, Max, you're either going to see them a third time, possibly a fourth. But if you don't manage to get yourself on the same wavelength as the patient, or they don't get themselves on the same wavelength as you, then I say, and Hesham, I'm sure you'll agree, you say no. You say no. I'm sorry, I'm not the right surgeon for you.
So I can't achieve it. I can't achieve what you would like to have. So, but I always suggest to have a second opinion.
Yeah. Hesham, do you take photographs?
I take them myself. Yeah. So
when do you take them?
I take them in the first consultation. I think it's important to do this because That consultation covers most things. You need to have to go through everything in the first consultation. If you go and send the patient away, then they come back again, it's not the same. It's good to have it while you're discussing the nose for the first time. I take the photos immediately and we go through the abnormalities on the photos as well, the bits they don't like, and then I use the computer software. And that will give me an idea, are they expecting too much? Because they keep saying, take more, take more, take more. And then the nose starts to look unnatural, then I know that they're not realistic. Yeah, or sometimes they're just not sure what they want to do. And again, that's not a good sign.
Do you take
the software is very important, to be honest.
Do you take photographs a year later as well?
6 weeks, 6 months, a year. Yeah.
Yeah, very important, isn't it?
Yeah, essential. There was a paper a few years ago that shows that I think 12% of rhinoplasty were done in the UK without photographs, which is really shocking, I think. But that was years ago. So hopefully it's not like this now. It'd be nice to be done again.
You also mentioned so many different angles, many different measurements, okay? The important ones you highlighted as sort of take-home messages, okay? Yeah. Just talk a little bit about having an aesthetic eye as a surgeon. And I'll tell you where this question's coming from, okay? So you can measure all you want, but if you can't see that a radix is low or a radix is high, or that the nose is over projected or under rotated, or if you can't see that the upper lip's too long, and this is sort of highlighted by nurses in clinic with you, or your anaesthetist, isn't it, who sometimes says, I don't see much wrong with that.
Yeah.
Because they don't have an aesthetic eye. Just talk a little bit about that.
So the aesthetic eye is a bit of a difficult thing to define. Is it natural something that some people have, or does it come from experience? I think it's both. I think some people can see details more than others, but it comes from also studying the nose a lot and looking at so many noses and reading so many books and attending so many lectures and watching surgeons. You develop it. So I don't think it's something that it is only natural, but some people have it more than others somehow. And that is essential. And you'll find yourself as a surgeon in the beginning measuring everything. And then later on with experience, you don't, because you could see it more. So I don't measure anything anymore now. I'm doing my surgery without a ruler or anything. I could just see it, I can expect, and I could see the heights of here and here and just compare them. But you really have to see that. You have to see the abnormalities. And you look at the nose as a whole and as units as well. And I think everybody like listening from junior perspective, read a lot, watch surgeons, understand their proportions and think about it a lot. Look at people's noses. I'm really sorry about this, but that's true. It works. But don't make sure that they don't notice you, but this is what I do all the time, or I did anyway. And you learn from that a lot. Yeah.
Hesham, so just to finish off with then, so you've mentioned COVID, and obviously NHS practice and training in particular has taken a real beating in terms of septal rhinoplasty procedures being categorised as P4 procedures. And there is still little prospect of great volumes of that sort of surgery happening in NHS hospitals and NHS practices, which is very different to the cosmetic type of operation that you and I have been sort of discussing for the last few minutes. What are your tips for our trainees moving forward now about how to make sure that they don't sort of miss out and they acquire those skills that are vitally important?
Yeah, this is a problem, and we just published a paper on training for rhinoplasty just like a few weeks ago. The numbers are less, and with COVID, the numbers are gone. In many hospitals, nobody's done any at all for a whole year. It's important to attend courses now because it's not going to be available in NHS as much. So hopefully courses are coming back, but read a lot as well. And I don't think rhinoplasty will go from the NHS. I think it's going to be there because traumatic noses are there. You cannot not do them. We've tried to redefine the area of what rhinoplasty that people should be able to do. And I think mainly the traumatic ones and humps, nasal valve problems. These are the main areas that they need to learn. And if you want to learn aesthetics, then that's a private practice. What I do is my fellowship, the fellow comes to the private practice, it's part of the fellowship. So people have to start developing this. So my fellows already, even with COVID, has been through maybe 70 rhinoplasties in the private practice because we've been doing them anyway. So I think that's really have to come to the training if they want to learn about rhinoplasty. Because not all the ones in the private practice are purely cosmetic as well. So many of them are functional. So I think that's the way forward here.
We'll finish off on just one sort of final question then. Is that there shouldn't really, Hesham, be a difference between what we're doing in our NHS practices and private practices. So it transcends. So there isn't a difference. And I know that you work like that. I work like that. There isn't a difference between what we do across the different sectors. Fair comment?
Yeah, definitely 100%. You treat the patient exactly the same. We take the photograph the same day as well in the NHS. But sometimes they delay it to be on the system. So we bring the patient again to look at them with the photographs. So that's another extra consultation, but the same. The only thing we don't do in NHS is computer manipulation, because that implies it's cosmetic. So that's the only thing. But in general, with everything else is the same.